עכשיו.
Okay, blood
רואה?
pressure is
אוקיי,
fine.
אז תשאיר, אנחנו נמרכז אחר כך.
אוקיי,
תראה שהוא לא
הוצאתי את
מדמם.
הוצאת את
אה?
האוויר?
שנייה. יש לי את ה... זהו, זה המסתם. כשבא המסתם הוצאת אוויר, לא עכשיו. זה שמור שלא יעוף לך. טוב, ג'ף. Whatever happened from here, this
All your
is you
fault.
for blood pressure, up and down.
Let's get rid of this.
אנחנו יושבים... שקף רגע, ג'וני, שנראה איך אנחנו יושבים? לא רע. אני אלך אחורה קצת. זאת אומרת, אנחנו נצטרך קצת לשחק עם זה.
בסדר, זה ברגע האמת.
כן, להעביר את המסתם. דבר אליי כל הזמן. דבר אליי.
12 תמונות.
כן.
זה צ'יק, אבל אתה לא נושף לי.
לא, אני נושך. אנחנו נראה את הזמן.
נושך לך אחרי 2.
נראה את הזמן.
יש לזה סדר פה.
נראה את הזמן. אני רוצה עכשיו שתגיד לי...
הנה, בוא.
לא, תקשיב לי, לא. אני שואל אותך שאלות, אל תראה לי כלום. אני לא יושב כל כך קואקסיאלי. האם רואים את זה שאני לא יושב קואקסיאלי? האם הווייר יושב באמצע? הוא ממורכז הווייר?
הוא קצת אקסנטרי, הווייר.
אנחנו צריכים את המסתם אצלנו פה. את המסתם אצלנו פה. אל תביא לי את זה לפה, תקחי את זה מפה. תגידי, למה אתם מעבירים דברים? לא מעביר, תקחי את זה אחורה. בואי.
60 שניות, ירון.
כן, בואי, תביא לנו את המסתם בבקשה. בנות. קדימה. בואי איתי. שיעלה לי את הכל.
אתה לא שומע אותו?
לא שומע טוב. קח את זה, ג'וני, זה שלך. שיעלה לי את הכל. צאי מפה בבקשה, צאי מפה. תעמדי פה. שיעלה לי עוד קצת. יופי. עכשיו הוא אליו. אתה שומע?
אנחנו לא רואים את וושינגטון?
לא, אנחנו רואים מה שיוצא מאיתנו.
אתה רואה, אני לא רואה כלום.
אתה רואה כלום. אתה הכל יכול. Shalom. How are you? Okay, thank you very much for allowing us to be part of the transmission this year, especially with the new acquisition of Giora Weiss, that we took him from you. Let me go ahead and present, first of all, the team that we are working with, and then we will present the case for you. So with me is Dr. Jonathan Balkin. We are the valve team, Dr. Zilberman, who is scribing with us in every case for valves, Dr. Fisher, anesthesiologist, expert, and we have Dr. Adi Butanero, who will show you beautiful pictures from 3D echo. So let me show you the first case summary, and then we will discuss what we want to do.
Hi, everybody. The case we're presenting today we think is tremendously interesting. It's a 65-year-old man who has coronary artery disease for many years. He had a bypass done in another center in the year 2000. It was fairly well until the year 2011 when he developed severe mitral regurgitation, and he underwent a replacement with a biological Hancock valve, 31 millimeters in diameter. He has in addition to that, he has at that time his left main was found, his lemur was found to be occluded, but he has an SVG which supplies the diagonal with good flow to the LAD. He has poor LV, he has an ejection fraction of less than 40%, he has a very bad RV which is dilated, and he has very severe pulmonary hypertension. Unfortunately, he developed very early deterioration of this Hancock valve, and he presents to us now in severe heart failure with severe mitral regurgitation. The surgeons feel that he is absolutely not a candidate for a valve replacement, as he has a surgical risk STS of over 29. So we have decided to go ahead today and to do a valve-in-valve, replacing that Hancock valve with a prosthetic Edwards valve.
Great. Thank you very much, Johnny. Because then I will forget, of course, I didn't mention the nurses here and all the stuff around us that without them, of course, we cannot do this case. So, Greg, this is a 31 Medtronic Hancock valve with internal diameter of 27. Quite big. And, of course, the only valve right now that we can use is Edward. And after consultation between us and others, we have decided to go ahead and to do this valve-in-valve with Edward 29, which is the biggest right now that they have. It's not something common. I don't think there has been many cases with a 29, which really needs a lot of precision, and the moment of dilatation, of course, of the implantation of the valve is very important. And let me hear your opinion. Okay, I mean, all of the above. We have used TE, we've used CT. We are using, of course, the company, Medtronic company, to tell us exactly what is the internal diameter. And I think one important aspect is our unit of structural heart disease really involved a lot Dr. Butanero with the new 3D guidance. And let me go for a second, Greg, if it's okay with you, to Adi, that he will show you how the valve look and what we have done so far regarding wiring of the valve. Is that okay? Okay, Adi.
Hello, I want to present you the images that we took before. This is an explained 2D image of the bioprosthetic mitral valve with the severe mitral incompetence, severe tricuspid incompetence, and the stenotic valve. We have a maximum anemia gradient 15 and 7 on this bioprosthetic mitral valve. A very nice picture of color 3D severe mitral incompetence. And this is how this bioprosthetic looks from the left atrium. We can see the bioprosthesis from both sides. On the left is the left atrial side, and on the right it's the left ventricle side, with very severe mitral intraprosthetic. Once again, it's a picture of a 3D, LA and LV. And this is, we are into the procedure. We can see very nice the catheter which comes through the valve from the left ventricle into the left atrium.
Adi, hold on a second. So let me guide you. We'll show you first the first image, the fluoroscopic image. And as in other, you have to find, of course, the right images. Can we go to fluoro? So you see the fluoro, and this is a beautiful image of the annulus itself and the 3 dots of the valve. So, and if you look at the right angle, the right side of the screen, these are the attempts that we are making to pass the wire. And it's obvious that we are not inside, and guided by, hold on a second, can you go to echo, please? Go to echo, please. Adi, can you show them? We were guided by Adi really to find the way that we can cross inside. ID.
And here we can see in the, if you can see, this is the left atrial side of the guide, which is in the bioprosthesis. We can see it very nicely. It comes from the left ventricle into the left atrium, as you can see. Once again, this is another picture of this guide, this wire, which comes into the left atrium.
Okay, so ciao Antonio. Okay, so we have crossed with a regular wire of the 6 French introducer sheath, normal wire. But the wire really was guided nicely by the echo. So let me show you the next. So after, of course, we crossed, come back. That's what you have? Okay, so after we have crossed Antonio with the regular wire, we have exchanged it to the extra support wire. And again, we were guided by the echo to put it in the pulmonary vein. 1 minute before we came alive, we put the sheath inside for the Sandra. So this is the 26, if I'm not mistaken, 24, 23, 26, I'm sorry, French introducer that is already in the LV coming from the apex. Can we show fluoro? Can we go live fluoro? And you see it is a little bit eccentric, but we have a little bit of room to try to negotiate and put it in more, let's say, central position inside the valve. So because the LV of this guy is not so good and all the other stuff, with your permission, we will go ahead now and pull the valve inside. Say it again, Antonio, I cannot hear you. So, the valve, okay, the valve that we take, Antonio, is a 3029 Edward Sapien from apical, you know, and this is the largest valve today that you have if you want to utilize it in transapical, either for aortic or for mitral valve in valve. The internal diameter is 27, Antonio. 27. אוקיי, בוא נחזור קצת אחורה. אוקיי, פלורו. All right. אוקיי, מי צריך? ג'וני. תעלה לי קצת לאמצע. תעלה לי קצת לאמצע.
Okay.
אוקיי, תחזיק. Johnny, need to find the fluoro that would be perpendicular with the valve. Slowly, slowly. That's all, that's all, that's all. That's all. יופי, יותר טוב, אתה רואה? יפה, כן, כן.
Okay.
No, wait. So guys, can you, Adi, can you show us the 3D echo? Now, what do you want to have? Fluoro. Can we have fluoro and echo on the same screen, please? Fluoro and echo on the same screen. So what you need really is to be 1 to 2 millimeter after the valve, you'd say after the annulus, and that should be 1 to 2 millimeter in the atrium side. And you see the 3 dots of the valve in the LV. So we are quite good and we are quite happy with the coaxiality of the valve inside the ring. But we will go again and ask Adi what he thinks. Adi?
So here we have a 2D image. We can see that the guide is quite in the middle of the bioprosthesis. This is an X-plane, which shows it very nicely of the 2D. Let's see how it looks maybe in 3D, Mali.
So what we want to see, Adi, in the 3D is if you see the exit of the valve into the left atrium, at least hanging outside, 1 or 2 millimeter. Now we are a little bit inside now. So we want fluoro and echo on the same screen, please. Okay, this is very good. So you have all of us together. תזיז אותו. תזיז אותו.
תזיז קצת אחורה.
Okay, I can hardly hear you, but what we have here right now, the patient doesn't like so much our video games, and exactly. Okay, guys, so the pressure drops down a little bit to around 80. You know why. So if you are happy, Greg, are you happy with the position? Okay. Antonio, you happy? Okay, Antonio happy, I am happy. Okay. Okay, that's what I did, Antonio. That's what I did. Exactly. Okay, now remember the... Exactly. Thank you very much, Antonio. Exactly. So we have to implant it very slowly, as Antonio said. Fluoro. Okay, now we are going to do the implantation. I think we are okay here. Jeff? Okay, so pace on. Okay, Johnny, slowly. Go slowly, we are okay, go slowly. Go up. Up. More.
It's fully inflated as much as I can go.
Okay, calm down. Pace off. A little bit. Can we see the echo, Adi? Can you show us the echo, please? So pressure is okay. I know, but it's still forgiving because we will see exactly now with Adi. Adi, can you show us the 3D also?
So this is a 2D picture, an X-plane, which is very useful for us. We can see nicely the valve. Mali, can you put some color right now?
So what do you think about the valve itself, the position of the valve?
No, we have quite a severe mitral incompetence right now.
So we need a balloon. Okay.
Okay.
All right. Of course, we
But
have the system
balloon-
inside.
Yes. Yes, of course.
Adi, we have all the system inside.
Yes, yes.
Johnny Floro.
Okay.
Johnny Floro. Please.
But the position looks okay according to the
Okay,
echo.
so we have MR. It's a central MR.
Yes.
Because, of course, because we have the system is inside and the wire is inside.
See the 3D.
So we will take it out. Okay, let me open here. We need Adi.
Yes.
Can you show us now, please?
Yes. Now we can
Johnny,
see on
Johnny.
3D echo the valve. Very nice. It looks that it's quite a good position according to the 3D. And if we can put some,
Can, whatever you want.
and we will try to put some color to. This is a dual image, a very nice dual image of the left atrium on the left atrial side and the left ventricle side of the prosthesis.
Susie.
Okay. Those are the leaflets that were, see, very nice. Okay.
Adi, MR.
ML. Let's see now, we are going to put color. Okay. It looks very nice.
Okay, very nice. Adi.
Very nice. It's a minimal,
Really?
it's a
Minimal.
functional, and it's a very good result you're on.
Okay, very good. Can you show us, please, Floro one more time?
It's very, very good. And this is on 3D.
The 23.
The Sapiens 3
Yes, you mean for the aortic or for the mitral?
for the mitral.
Okay, so as you know, Sapien 3 was the idea came from Israel, but Edwards unfortunately doesn't bring us the valve. So unfortunately, we don't have S3 in Israel yet. So this is third world country, so we don't have an experience with that. Yeah, could be Antonio, but okay. Floro. Okay. Yeah, beautiful result. We are very pleased. Remember, the patient really is very sick, and he really was so afraid to go. But I think with the help of the team here, but let me again say that it's a beautiful team that we have for the heart valve and for structural. And I thank again all the people. I will move to the other room, guys, and they will. Yes. Shuli, do you hear them? Okay.
Well, we had prepared the purse strings on the apex as is a routine procedure. We will just tie them down. We don't expect any problems. We did not dissect the pericardium, which is adhesed to the heart, which helps us with reinforcement. And we don't expect problems, but we'll see in a few minutes.
We've done it. Shudi has extensive experience with this without. Right. Yaron has gone across to the other room. And thank you very much, guys. We're going to close up here.
Microphone off. Huh? Start protamine? Okay. Firas?
סיימנו? כבר לא שומעים אותנו?
לא יודע. טוב, תביא לי את זה, אני לא זוכר. אתה רואה את זה מפה?
אתה רוצה להיכנס? ניתן לך את זה.
זהו?
אתה לא רוצה את זה? אתה רוצה את זה יותר נמוך?
לא, אני רוצה אותו פה.
את התפקוד חדר שמאל. עכשיו, איך הוא נראה החדר בכלל? פשוט לעזור לי קצת עם הניתור. שולי, להתחיל לפרוטומי?
לא, קח את זה,
Um,
תהיה מוכן להדק,
Ricky,
אבל לא ב...
אנג'יוסיו.
תחזיק את זה רגע קודם. אוקיי. אני אוציא את זה.
אני אוציא את ה...
תהיה מוכן
פלסטיק.
להדק. תהיה מוכן להדק. אל תוציא את הפלסטיק, תהיה מוכן להדק. בסדר? מוכן? בכל מקרה לא בפראות, מה שלא יהיה. אוקיי, מוכן? אל תהדק עדיין. אוקיי, תהדק. אל תיבהל. אוקיי. בלה, מישהו יכול להוריד לי את המיקרופון?
here is.
מיקרופון איפה הוא?
לא יודע.
Yeah, I can hear you. I'm gonna move it across. תגיד לאיריס שיעביר את השידור לחדר השני.
שנשאיר את זה תולה עליך?
הוא לא עשה את זה, אנחנו עובדים פה.
יש לך וואי, נכון?
נגטיב, נגטיב.
אני עושה נגטיב, אני רק...
איזה בלון זה?
זה 2.5, 20.
לא רואה את המוניטור מולי.
זוז לו מהמוניטור, קח את המצלמה שלך הצידה. באוויר. אתה באוויר. רגע, הוא באוויר. לכן אמרתי לך, הרצל צריך להיות על מצלמה. הרצל, אל
תכווני את זה עליי.
קחתי לשאול.
עם הרגל, עם הרגל, עם הרגל.
קח את המצלמה הצידה.
תעזבי, תעזבי, תעזבי. אוקיי, תבוא.
הנה, אתה באוויר, ירון.
Okay, guys. Greg. Hi, Greg. Greg, hi. We are good, we are good. Thank you very much for the support for the valve-in-valve. I think it was great case clinically for the patient. Let me show you what we are doing now and introduce the team here. Again, what we have here is Dr. David Merkin, which is the head of the structural heart in the cath lab. We have on his right Dr. Goldin, which is the head of the vascular surgery in the hospital. The reason we are all three of us together here, I think, is important because we want to show you something really interesting. And let me go over the case with you. And this is the first time you will see it most probably in the States. So the patient is a 76 years old patient. He's an old patient of mine with multiple interventions that I did over the last 15 years with him. We have done, of course, PCI. He went cabbage like 15 years ago. I've done PCI on his SVGs. He had uncontrolled hypertension and rise in creatinine. We have found tight renal artery stenosis, which we have opened a few years ago. And the patient nearly 5 years ago had an event of TIA and found to have 80% of his right carotid artery occluded. And we have implanted a stent at that time. He's here one more time because we are doing every 6 months duplex on his left, which was 50 to 60%, and I will show you today that is occluded up to 90%. And I think he's 76 years old, and the reason we will show you this case is that we will love to show you a new device that comes from Israel, and this is a new CGuard stent, which is the newest version of a carotid stent. The nice thing, and I hope you can show slides or video images, is that if you have it, the nice feature of this stent, which is completely open cell design, it's a nitinol stent, one filament, really open cell, and the stent is covered with a mesh, with a micronet, the same micronet, a little bit different than what we are using in MGuard in acute MI. The nice thing about the net is while the stent is expanding, is that the net will open more in the biggest part of the common carotid and will open less in the internal carotid artery. And really it ranges from 120 micron to 180 micron, the part that is open. So I think it's important. We wanted to show you. I hope everything will go okay. And David, can you describe what you have done so far?
Sure. We've commenced, if we can get up a fluoro shot. Let me just see if I can actually go backwards for a second. There we go. So if you can see our fluoro shot, we can see now a common carotid that's around 6 millimeters with the lesion beginning from the common carotid and progressing to its tightest portion inside the internal carotid, a lesion of approaching 90%, I suspect. What we've done at this point is we've prepared with a couple of shots and we've positioned an easy filter 300 millimeters long in the superior portion of the internal carotid, preparing ourselves so that we can go ahead to perform the stenting.
So the reason we are using the long easy filter is because right now this is the first version. This is the first version of the stent is over the wire. And of course it will come monorail in the future. But as you see here, this is almost 90% carotid stenosis on his left carotid artery. So, sure. אטרופין, מוכן? אטרופין. בבקשה ליד החולה להיות עם מזרק אטרופין. בזריזות. בוא נעשה דילטציה. חצי מיליגרם אטרופין לתת. שנייה. שפריץ קטן.
שפריץ?
שפריץ קטן. אוקיי, עלה. עלה.
כמה?
עלה. 10. בוא תראה איך הוא מתנפח. הוא מתנפח לגמרי. רד.
אני רק ב6. רק 6.
תביא לי בלון 3.5. 3.5 בזריזות. בוא נצא.
רק תזהר על ה...
הכנו את הכל, 3.5, 20, הכל מוכן. 20. תביא לי 3.5, 20. יפה, מה הוא אומר? שנייה. תביא, קח.
אני לוקח. קח את זה. תנתק.
Okay, so yeah, Antonio points, I think it was Antonio, is a very good one. Not only you have to be careful while you implant the carotid stent, is also the late event during the first 24, 72 hours and maybe 30 days. So I think, yes. So now, the system right now is a 7 French system right now. So we are using 8 French guiding, which come up really nice. And let me tell you that we have done, I think in our institute, more than 400 cases and most of the cases we are doing without pre-dilatation. But right now with this device, we have to do pre-dilatation spritz, okay? Because we want to make sure that the system will cross nicely. So this is a 375 balloon, goes up to 6, 7, 8 atmosphere. Come down. And you will see that the reason that we are doing it, balloon arba, that we are doing it is because arba non-compliant, 4 non-compliant. That we want to make sure that we can bring the system nicely inside. Let me tell you one more thing about the system. There is no foreshortening with this system. So if you put a 30 millimeter long stent, you will be end with a 29 millimeter stent. And this is really nice. And the other feature that I think that Dr. Schoffer, Joachim Schoffer, is going to present, the first in man done in Europe, is that because of completely open cell design, the stent will adapt nicely to any curve and will really lie on the net that will go between the stent and the artery wall. So it's like soft implantation of the stent. We know that also from MGuard that this is the case. And I will be very curious now to see when we implant the stent how the external will be affected, because this is big plaque that goes from the common carotid right to the internal. So okay, this is the wall stent, Antonio. So Antonio, unfortunately there are only unfortunately there are only 2 carotids, so we can compare only 2 stents. שפריץ קטן? נגטיב, נגטיב קודם, נגטיב, שנייה, נגטיב. Okay, small spritz. Okay, עלה. Let's see if the balloon is very open to see if it's open. Okay, let's open it. Open.
Yes, sir.
Open. 12. Down. תביא לי את הסטנט. 7:30. 7:40. Okay, Greg, this is the key. I want to make sure that the stent, which is a 7 French right now compatible, that I can implant it and bring it back safely home. I learned from the guys in Poland and from the guys in Hamburg by Joachim that this is really wise to do pre-dilatation, because you want to make sure that the stent will be implanted nicely. Did you hear it?
Yeah.
I don't hear it well.
Why did we do stepwise pre-dilatation?
Okay.
Stop. זה קשה.
Go. Okay. תראה את זה. Yes, so, תראה לי את זה. אני לא רואה, ארז, I don't see... Can we go live here? Okay.
על הירוק יותר טוב. על הירוק יותר טוב.
Okay, so the step, I'm sorry I cannot hear very well, but the stepwise, Greg, was really to see if this is fibrotic, calcific, or softish lesion. I don't want to be surprised here. And as you know, the work that was presented in TCT last year by the guys from Austria showed that the pre-dilatation is not the one that really caused debris to go to the brain, but this is the stent implantation itself and the post-dilatation. So we want to just to make sure that we will do the right thing. This is the first case done in Israel and one of the few done in the world. So this is why. And we are having the filter distally, so we feel quite comfortable to do this pre-dilatation. Okay. David?
Yeah.
Okay. All right. So let's see the filter. Let's do together now.
1 second.
Okay.
Go back.
Now, you remember from last 2 years, is that the David is sitting because of his back, not because I want to be higher. Okay?
Yeah.
So we will go ahead now and do the stent delivery, and then do post-dilatation, and then, if you are happy, we can finish this 45 minutes transmission. But I'm really thrilled about showing you this stent, because I think it's an important step in the future if we can show that this will be beneficial. So you see the cone. The cone really is the one that leads the system. And you see the stent that lies in between the two markers. And as you will see immediately, there is no foreshortening at all. So we will just... דוד, אני לא שומע אותם. אני לא שומע, אתה שומע?
Sorry, can you ask that question again?
ברווז? ברווז.
The stent length is 40 millimeters with a stent diameter of 7.
Spritz? Spritz, כן. Okay, so we will implant the stent now, and you see we are above the lesion. We are nicely positioned in the... תפתח לי את זה. We are nicely positioned in the pommel. תפתח. And we will release the stent right now. And you see the crowns open. You see the markers on the stent. I'm coming down right here. And that's it. The stent is released. So what you see here really, which is nice, is that you see how the stent adapt nicely to the wire, which really permit the stent to be adapted to the anatomy of the vessel. And I've seen cases from Germany really that if you have an S-type lesion, this will take the S-type shape. So the stent, this stent, particular stent right now, comes from 6 up to 9 millimeter in diameter, and it can open from 5 millimeter distally in the internal carotid up to 9 in the common carotid. We have elected at 7 because we have measured the, so you see it here, this comes really nice. I want to, okay, David, you can take it out. Yeah, now you need right now 4 hands. But luckily, I have Dr. Goldin and Dr. Mirkin hands here. תביא לי 15. And we will take a picture, do post-dilatation, and we'll let you go. If we have 1 minute, תביא לי 5 מהר. So, עוד קצת, דוד? עוד קצת? Oh, well, כן, כן, אבל אין לי אותו ביד, אתם מחזיקים אותו. אתה מחזיק אותו, תן לי אותו, תן לי אותו. הוא לא יוצא. עוד קצת אחורה, עוד קצת אחורה. עוד קצת, רגע, עוד קצת, זהו.
זה היה תקוע על ה...
אוקיי. 5, לדיוויד. שלם. אוקיי, so the radial, דיוויד, בוא נעשה post-dilatation שנוכל לעשות תמונה. So the radial, guys, the radial strength of each point of the stent is excellent. So,
כך.
okay, אני רואה את זה. Okay, so we will do the post-dilatation for you,
תשמור לי על הוואי.
and the patient feels well.
שמור לו.
So we have elected to go with a 5-0.
Go.
עזוב, תן לי. 5-0 balloon. Negative.
כן, זה בא.
And as for the radial strength, I didn't hear the discussion, but since this is a very open design, okay, 1 מיליגרם לתת, 1 מיליגרם לתת, עכשיו לתת, אוקיי. עלה.
כמה?
עלה, שיתנפח. אוקיי, so we go up, 6, 7, 8, 9,
10.
10, go ahead. So what you have heard is the doc, the patient is trained with procedure. So he remember, whenever he feels pain in the neck, he should put some air in the duct, so you feel the duct. Okay, we'll give you.
Injection.
Okay, we'll give you test injection, and then if we need one more dilatation, we'll do it. Hold on a second. In 30 seconds. You ready?
Yeah.
Ready? So, go. זה לא מספיק, תעלה. Yeah, it looks okay. Yeah, now, Greg, remember that the plaque was also at the origin of the external. So it's extremely nice to see that the cells in the net are open, and the flow is great to the internal and to the external. Okay. Okay, so...
הוא רוצה שתוציא את הפילטר, אבל אנחנו רוצים עוד dilatation.
Okay, you want to see the filter goes?
No, don't take it out.
No, we'll do it off camera.
Yeah, but we actually want to do another.
Maybe.
We want to assess the possibility of another dilatation. Yeah.
Okay.
Yeah.
Okay. So thank you very much, Greg, for your patience. Thank you again. נוזלים לפתוח. Thank you very much, Greg. It's a pleasure to be again with you.
We'll see you soon.
See you soon. Okay. Thank you very much. נוזלים, לפתוח נוזלים בריצה. דוד, אני לא חושב, עזוב, למה אנחנו צריכים לזהו?